Thank you, Adol, and good afternoon, everybody. Uh, so, we were talking about symptom control and communication ethics, etc., for the last 16 or more sessions. But today, we are going to cover another important session. Uh, and this is important, especially if you are planning to start a palliative care unit. And some of you may want to start palliative care unit, and in such situation you don't know what to do, what all things need to be done, and how and where it has to be started, and what all resources are available. Things like that is important. So today's session will be taken by Mr. Binod Hariharan. uh, Actually, he's an engineer, and currently he is the MD of two companies, but he is one of our trustees, and he has been associated with Palem India since its beginning. So uh, he would be a better person to tell us regarding how we can organize palliative care services. So welcome, Binod, and it's over to you.
Hi, hello everyone. Thanks for that introduction, Sunil. And my name is Binod. And as Dr. Sunil mentioned, I'm not a doctor, basically trained as an engineer, but more on the entrepreneurial journey, I would say. So you might be wondering, what this person, is doing here, talking to a team of doctors, I believe. Uh, am I right, Sunil? All of them are doctors, right?
Yeah,
Doctors, I guess, yeah. And from different parts of the world? Or is it just
yeah.
within India?
I don't.
Yes, sir. They are from different part of the world. I think from other than India, they're from somewhere from Nepal, Bangladesh, UAE, Nigeria, and South Africa.
Okay, wonderful. So thank you for having me here, and good morning, good afternoon, good evening to all of you. So as Dr. Sunil mentioned, this is going to be slightly different from the topics you've been used to during this course, FCPM. And we are going to look into the organizing aspects of palliative care. And I believe, Arun, these slides have already been shared with the group, all right?
Yes, sir. Yes, it's already shared.
Okay, wonderful.
Mail and WhatsApp.
Wonderful. Okay, thank you. So what we'll do is we'll not go through the slides slide by slide. In fact, of course, we'll pick up the relevant ones, and we'll have more of discussions. And you are all free to bring up any specific points you find useful or interesting, or which you want to discuss about from within the areas that we have mentioned here. So why have we included such a session as part of this course? So typically what we see is doctors and nurses, in fact, even social workers, get trained in palliative care. They undergo a course, like sometimes even a 6 weeks course, which we organize full time. And then when they go back to their home setting, in the sense, it could be, you could all be working in either a hospital or your own clinic, or maybe working with an NGO, or having an independent practice. So depending on your background and with the knowledge that you have acquired during this course, you might want to, at least some of you might want to go back and practice what you have learned. And that is where you start finding challenges. You may, for example, end up in a situation where you try and integrate or try to incorporate some of the learnings that you have had into your hospital, into into your regular practice in a hospital, a multi-specialty hospital, for example. And then you find that it is not that easy. Like, there are very few people around you, including your colleagues, who are aware of palliative care, let alone be trained in palliative care. Sometimes you may end up having questions like, why do we need to take care of the pain when you can always look at the source, diagnose the exact cause, and solve that problem, and the pain will automatically go away. Or sometimes you may face situations where there could be questions around what you've been trained to do as a physician. For example, you're always taught to maintain life. How can you support death or allow a person to die? Now, these are situations where you find yourself in a struggle, and most often with your own colleagues. And there are other situations, like you may want to go forward and do something, and then the management may come and say, this doesn't work for us because it's not financially viable. We can't ask a person or a patient or a family to let a person die in our environment. So there are management issues on one side. There are other probable challenges, like getting access to some of the pain relieving medications, like opioids, for example. So there are a whole lot of challenges. And of course, the lack of awareness about the general public. So often what we find is, after getting trained in the principles of palliative medicine, many of the doctors or the nurses who get trained are not able to practice it. And that is why we felt, it's also important for all of us to have a general idea about what are the possible scenarios that we could face and how to go about doing it, at least the general approach. Now, we have just an hour and a half. Now I think it is only an hour and probably 15 minutes. And it's a challenge covering the entire range of topics. So, but we'll try to go through the most important slides and spend some time on it. And I would request you to raise your hand, or voice your suggestions or whatever you have, comments in the chat, and we'll pick it up from there and probably discuss something more about it. So Arun, I can share my slide, right?
Yes, sir. Yes, sir, you can.
Okay, let me see. Okay. So is this visible to everyone?
Yes,
hello?
Sir. It's
Yes.
visible.
Okay. So we are going to focus on a few topics, like the essentials of palliative care, the challenges that we face in India, the relevance of involving the community, need for a collaborative approach, and some tips on advocacy and fundraising. So we're not going in depth into it. Of course, we can have further discussions if need be, one-on-one, or whichever forum you choose. So Now, this is something which you are already familiar with. And now I believe all of us realize that all this, the palliative care approach, if you need to put it into practice, it requires an interdisciplinary approach and a coordinated continuity of care to be given to the patient, in different settings, like it could be a hospital, a hospice, long-term care facility, whatever. Now, we also realize that this team includes all these people and more. When I say a team, it definitely includes doctors, nurses, social workers, but there are others which we often tend to forget also, or we don't consider as part of the team. And one important category is the last one, that is the family and other caregivers. Now, even the patient, we often tend to forget that the patient is also a member of this team, because unless he or she is also part of the team and trying to or extends their cooperation, and also involved in the decision-making process, we'll often find it very difficult to help this family or the patient, take decisions, implement some of the suggested solutions and all that. Now, essentially, we understand that anyone who can contribute in improving the quality of life of the patient and family has to be part of the team. Then only it would be most effective. Now, sorry, I think I made a mistake. Okay. Sorry about that. So I'd just like to present a scenario for us to have a small discussion. Now, this is a scenario. You find a neighbor, a lady, screaming all through the night. You can hear the screams. So being concerned about this person, you go ahead, do a preliminary inquiry, and you understand that the person is a cancer patient. She's in the probably an advanced stage of cancer. And there is a multi-specialty hospital nearby and also a government hospital. And there are also doctors and nurses whom you are connected with. But then there are no palliative care facilities that you are aware of in that vicinity. Now, my question is, or rather, the point to be discussed is, what do we do? What do you think should be the approach? How is it that you, as a person in this scenario, would intervene or be involved? What would be your next steps? So this forum is open for discussion. You can put your suggestions in the chat box, or you could raise your hand and then use unmute yourself and talk. It's up to you. Thank you. So I'll just listen. I'll just wait for your comments. So I'll just repeat the scenario. We have a lady, a neighbor, who is screaming all through the night. You understand that the person is a cancer patient. There are a couple of hospitals, at least in the vicinity. And you also have contacts like doctors and nurses whom you know directly. So what do you do? What are the possible things that you would contemplate or do? I will do palliative care up to my limitations as a doctor and neighbor. Thank you, Archana. So what is the first step that you would do, that you would take? So I understand that once you're trained in palliative care, obviously you would like to extend that care. There are some options, things to do, seems to be getting involved personally. Yes, Geeta, so you would get involved personally, that is good. So what would be, find out about availability of morphine, relief for suffering. Asha says, I will go and talk to the lady. Yes. Asha, could you just explain a bit more about what you said? What are you going to talk about? What is the status? Yes. What is the status?
I was saying that I will go and first find out about the lady. Like it's just said, what stage of cancer she is, what are her other needs, like whether what is a financial need, whether it's a well-to-do lady or she has other burdens and all. Based on that, like if she is not a very well-to-do lady, or I will refer her to a government hospital based on her needs and all. Like there are other factors, we just know that here she's crying at the night, but there would be, as we have studied, we have her emotional needs would be there, there would be some personal needs would be there. First try to find out about all those things, and then I will go and visit with her doctor, like whatever is her concerned doctor she's showing, I'll go and visit with her once, as her friend, to find out what are the options that the doctor provides. Like I just can I wouldn't, I don't like to tell my friends and all, maybe she won't accept it. Like she's already visiting a doctor and I say no, this doctor is better, she may not take it the nice way. So the best thing is to go with her and find out what are is the options already she has, and then find out a better way to deal with it. And then if she is a palliative patient, like if no, there is no hope, or she's going to worsen, whatever the doctor suggests, whatever, based on that I will plan my action accordingly. Like now I have a forum in the form of tips. I know people. By coming into the program, I can definitely contact them to guide me in my locality how I can approach this lady.
Wonderful. Thank you. Thanks a lot. Now, I can see that most of you have mentioned, take a proper history, talk to the patient, then to the relatives, the family, and regular be in touch, follow up, reasons for not availing palliative care. What are the reasons? So basically what we are talking about is trying to understand more about the patient and what his or her needs are, and the family's needs, the background, all those things. Basically, it's all about active listening, right? I'm sure you must have gone through the communication, the classes, the sessions on communication, and I know that you would be able to handle those kind of things. So definitely, yes, that would be the first step. Go there, try to understand what the situation is, and then probably look at the possible solutions as well. Okay, now a slight change in the scenario. Assume that I am the person going there. It is my neighbor. It's not you. You're all doctors. I'm not a doctor. So what do you expect me to do in a situation like this? Now the question is a bit more complicated, right? Yes, Geeta, palliative care largely does not exist. That's a fact, yes. But then I have this neighbor and I cannot just, I hear her screaming all night. I feel, as a neighbor, I feel like doing something naturally. And I definitely am not comfortable hearing her screams and going to bed at night, right? So what do you expect me as a or a person who doesn't belong to this palliative care or medical care community or the healthcare community? Seek help. Okay. Where, Vinayak, where do you think I should go and seek help? Yes, definitely I can still sympathize, arrange financial help if needed, yes. General practitioner who can guide you to palliative care teams, seek help. Again, I need to get to a practitioner. But do you think I should be doing the first thing what you suggested, going there and understanding more about the patient and family, the background? Or should I just go there and say so-and-so is available? You know, you can go there and meet the doctor. So is that, I'd be very happy if someone unmutes and you know, talk. Oh, I thought you were speaking as a family member. Sorry, okay, got it. So I'm not a family member. I'm still a neighbor. Only thing is, I'm not a trained medical professional. That's all. Yes, Vinayak.
Sorry, there's some problem with my connection. But yeah, if you are someone who is not a family member, but who is trying to explore options to help them, then as you said, the first thing would definitely be to go and, you know, speak to them in a non-invasive way. They might also not want help in, so I mean, that's first thing that we have to respectfully ask them if, you know, they're looking for avenues in which they would want any help. And if they are, and if they are willing to look to gain help and, you know, take help from others, then I think one thing would be, of course, to, you know, connect them to a general practitioner, and a general practitioner being the, you know, always the first point of contact for our healthcare needs in India. And then, of course, you know, following their advice and what would they recommend.
Okay, great. Thanks. Any other suggestions?
I just wanted to say that palliative care is almost a missing element in the health system. So it seems there are very few port of call, I mean, doctors that you could contact, whether they are general practitioners or specialists who would know anything about palliative care. So this is probably the point in time when most of us will probably have to start thinking how to develop palliative care services, either in the hospital where we work or as a, you know, larger system eventually. But it's just the helplessness of the situation. There are no answers. As far as I can see, even in Nepal, there is one hospital, which is the INF hospital where Dr. Dumkumari works. And then there are one or two medical colleges which don't see enough cases anyway. So very, very limited availability of palliative care knowledge and information and services.
Yes, totally agree with you, Geeta. So that's a fact, that's a reality. So as a layperson, that's a dilemma that I'm in. I don't even know where to take that person to, or even recommend whom to recommend, because there are very few options available as far as, you know, this kind of care is concerned. Of course, you probably thought that I am aware of palliative care, and, you know, I'm looking for, or rather suggesting, that palliative care approach is required. I may not be a person who is aware of palliative care at all. Actually, this was a real life scenario. This happened a few years back, around 30 years back, in a place called Calicut, which is in the northern part of Kerala, where a person who was running a printing press, he was not even a graduate. he found he was in a similar situation. But that person did not stop there. What he did was, he went, encountered, of course, understood all this background, and he wanted to help. He wanted to do something for this patient and the family. So what he did was, he went around. He went around talking to people whom he knows, including doctors. He went to the hospital, talked to some of the doctors there, and after some struggle, he was finally able to at least get in touch with someone, a doctor, who told him that, this person probably needs pain relief, and that is something that we need to address. And we look for someone who can provide that pain relief. Now, one thing what all of you, I believe, agree is, a person like me should also be involved. I should also go out and venture out and try to understand what the patient is going through, his needs, his suffering. And then you believe, at least I feel, you are also with me on this, that there are things that I can do. Like, for example, here, someone said, at least, Dr. Bismi says, can still empathize, arrange financial help. There is always something that a layperson can also do. Now, that is a good start, because now you have made me part of your system, or you have let me in into your community. So when I say, so are we in agreement here? Now, palliative care is everyone's business. It's not just the doctors, the nurses, or the social workers who are trained in medical or healthcare. It's not just them. It's a person like me who has got absolutely no idea about what pain is, or even I don't know how to provide relief for pain, but still you are letting me in as part of your team. And thank you very much, because unless that first step is taken, unless you let me in, I will not be able to contribute. I will not be able to offer anything from my side. So that is where volunteering begins. Now, the reason why we went through it is this story. I'm sure most of you are aware by now that palliative care, it started off, at least the way we see it today, the way it is spreading across the country. It started off way back in 92, 93 in Calicut Medical College, where it started off with a few doctors and probably a few PG students who were interested in offering some kind of help and relief for patients in pain and terrible suffering, where the typical hospital or the existing medical system was not able to offer anything more. You might have heard this often in your hospitals also, that you reach a point where you end up telling the patient that there is nothing more that can be done. So this person was not happy. This person who ventured out and tried to identify a solution for this lady, he actually got in touch with someone who could actually address this kind of pain. And they got together, and that led to a movement. And that movement, the palliative care movement in Kerala, it started off there. And what was special about this? Of course, palliative care was already available in most parts of the developed world, the developed countries. But then there was no model for palliative care in the developing world, where, as we call it, the third world countries. Now, what actually happened was a new model evolved out of that. the peculiarity of the model was that the community was involved. The lay person was involved in healthcare. And that changed everything. And that changed a lot of preconceived notions about healthcare and who should be involved. And that is where we are now. I mean, that is the reason why we all agree that it should be an interdisciplinary team, and it should also involve the family, the other caregivers, and anyone, even the community. And we all believe that it is everyone's business. Okay, so let's move on. Now, I'm not going to go through each one of these slides, but in case someone wants to discuss more about a specific slide, in case you have gone through it already and you want to discuss more, we can go through it. Now, there are things which, okay, so in case you are setting up something on your own, that means you need to take care of some of the statutory requirements and make sure that you follow all of those. And most of these things, if you're not following it properly, it could land you in trouble, like the necessary licenses that you need. I'm sure you must have gone through that opioid availability, the sessions on what you call how to you know, the regulations related to morphine and other opioids and all that, how to store it, dispense it and all. So make sure that you follow all those. And often we find that, you know, these kind of services, when you start thinking of it, you need additional funding. Obviously, there will be very few facilities or very few hospitals which would be willing to start off with something like this as part of their regular the offering. So you may need to raise funds, in which case, if you're doing it separately, make sure that you have separate bank accounts and proper books of accounts and all that, because here, I'm sorry, the power has gone off. And I hope I'm audible at least.
Yes, sir, you are audible.
Yeah, we'll continue. Sorry about this. So those things we need to take care of. Now, this is again something which it's a reality now, even after these long 30 years of PC palliative care being practiced. There are big challenges, especially in a place in a country like India. And these are things that we are already aware of. That's the reason why palliative care was already more popular in some of the Western developed countries rather than in the developing world. So, as you know, there is the healthcare delivery at the macro level, which includes all the hospitals and other healthcare institutions that we are aware of, and whether the healthcare community accepts it or not. Ultimately, it all boils down to the micro level, the family, which is the primary service provider, I would say, as far as healthcare is concerned. Because if I have a fever, the first level of help or support or care that I'm going to receive is going to be from my family. It would be probably my wife, my children, and sometimes even my parents. I'm pretty sure that that is a scenario for almost all of us. Now, this is something which we have to accept, but this new level that we see emerging, the community, we call it the meso level. Now that is something which, as I said earlier, which has changed a lot of things. which has actually revolutionized the way healthcare is perceived, at least in Kerala. Now, let me ask you a question. You know that this palliative care is very popular in Kerala. The availability, as I say it, access to palliative care, it's quite high. The government claims it is somewhere around 60%. Let's keep it as 50%. Now, what do you think is the percentage as far as the rest of the country is concerned? You can just put in the figures, whatever you feel is appropriate. I'm saying, what percentage of the population who needs palliative care have access to it in India in general? I'm not talking about, Geeta says 2%. Okay, 1%. Okay, any other guesses? Less than 1%. Oh, it's going lower than that. That's very interesting. So is there anyone who is more optimistic than this? I was about to say 105. Okay, okay, 10. Okay, 10. All right, so yeah, so I can see that it's always, I mean, it's more or less in that single digit area, which is a fact, Now, they claim it is somewhere around 3 to 4%. Now look at where, yes, of course. So let us assume it is 3 or 4%, and look at the need, the gap, and how do we address this in a country like India, where we know that the government is struggling to even take care of basic healthcare needs, or even a basic immunization program, or maternal health care, children, the what do you call, the basic food for most of these families. Now it's a huge burden, it's a huge challenge. Let's accept it. Now, in these conditions, how do you expect the government to reach out to the people who are practically ignored by the healthcare community, who have already been made to understand that nothing more can be done? And to take care of these set of people, you need money, but it's not money alone that's enough. That's required. You need a lot more than that. Like, for example, I may have the money with me, and maybe I really want to have this palliative care. Yes, COVID has worsened this balance even more. Yes, absolutely, Avnish. No, even me being aware, it doesn't solve the problem. Like earlier, Dr. Anna was saying, there are very few places where you can find the care. You can't just go to a hospital and ask for palliative care. You may not get it there. There are very few practitioners who are trained in palliative care. There are very few nurses who are trained in palliative care. So it's not just the money. It's again, even if you have that kind of trained professionals, there is a huge gap in awareness also. So what does that mean? Now, the problem that we are seeing is not just about availability of morphine. It's not just about the doctors like you being trained. It's much bigger than that. It's about awareness among the community, acceptance of this kind of care. So Geeta says, can Ashas be trained in basics of PC to be able to make a basic diagnosis and refer patients to? Absolutely, Geeta, you are spot on. And that is what is actually happening, at least in Kerala. I can say that. Asha workers are involved. Of course, the rest of the country, at least in some areas, it is being tried out. Why Asha workers? We'll come to that. Maybe we'll go through another story and we'll reach that. But this is a brilliant suggestion that you made. So it's about unlocking this huge untapped potential. We call it the social capital, which is the community. So a lot of problems that we see or face or we see as challenges, it could actually be solved if we involve this community, empower them. Yes, absolutely. Empower the grassroots and bring behavioral change in the community. So we can't wait for the government to step in and do all these things. We can't wait for the government to actually educate the public and then, provide all this care and all that. No. So what does that mean? So I'll just give you another example. So I'm just going to stop the screen share for a moment. Now, this person whom I was referring to, the guy who got involved in the care for that cancer patient, the lady, he was involved a bit more from then on, and then he used to be a regular visitor in the government medical college, which was nearby. And there, one day, he found something interesting. He saw something interesting. So there was this gentleman in his 40s who was having a conversation with a doctor. And then he finds that this person, after that conversation, is totally dejected. And he's going and, he's sitting in a chair all by himself, a worried look on his face. Now, our hero, his name, by the way, is Ashok Kumar, probably the first, I would say the first palliative care volunteer in the country. Now he goes to this gentleman and asks him, what is troubling you? And then this gentleman says, I came here to meet the doctor, and it was for my mother, who is very ill at home, and she needs medical help. So then our hero asks him, what is the problem then? So what did the doctor say? Doctor said, doctor has asked this gentleman to bring her to the hospital. So again, Mr. Ashok Kumar says, okay, let us bring her here. I can help you with that. Let us arrange an ambulance. We'll go pick her up, bring her to the hospital. So obviously the doctor wants to see the patient and then look at the course of action, what is to be, naturally the diagnosis and all those things. So this person is still not happy. He says, no, I don't think that is feasible. It's not practical. I can't get her here. Now again, Ashok Kumar is confused. So what is the trouble? I'm going to help you. I can arrange the ambulance. We can go pick her up and bring her here. Now this gentleman says, I live around 10 kilometers from here, from this hospital. But to reach my place, there is no road. And I need to cross 4 to 5 canals. The small canals that you find in the villages, especially if you have been to Kerala, you would really understand what the type of canals that I'm trying to mention here. So these are small canals which crisscross the entire state, and to cross these canals, often you find the only the bridge, as you call it. It's probably 2 wooden, pieces put across these canals. And most often in Kerala, it would be a coconut, the trunk of a coconut tree. And this person's mother is 70 plus, and she is bedridden. She's a bit on the obese side, quite heavy. And for this gentleman to carry this person or take her across to the hospital, it would mean at least 4 people carrying her on their shoulders and crossing these canals to bring her to the hospital. Now that is the challenge. So imagine that you are in that situation. Now you're a doctor, a patient comes to you, and then this, not a patient's son comes to you and asks for the service. What would you do? How do we solve this problem? The gentleman is not able to bring the patient or his mother to the hospital. The doctor cannot advise anything unless he or she sees the patient first. So any suggestions? Yes, absolutely, Avnish. I like the, yeah, Geeta says need social workers, volunteers. Okay. Yeah, airlifting would be the ideal solution. Maybe in the West it would happen. In a developed country, yes, that's probably the solution. But in India, I'm sure you'll all agree that that's out of the question. So need social workers, volunteer. What, Geeta, could you just explain? What do you expect them to do? Like this person, Ashok Kumar, is there.
Go and visit the patient, of course, and talk to the patient, make an assessment in terms of whatever training the volunteer has received, and then come back, our counsel, of course, and then come back to the hospital and talk to the doctor, and then see what can be arranged, including, pain relief at home. Because I know those, what shall we say, Toda, that we have to cross in Kerala, and no way we can carry a heavy patient across that. So yeah, very difficult situation. All these patients are definitely the ones who need so much help, and absolutely no answers to this anywhere in India or Nepal.
Okay.
I suppose in Bangladesh too.
Okay, thank you. So anyone else, any suggestions? So
Dr. Avni says telemedicine.
Sorry?
Dr. Avni says telemedicine.
Yes, telemedicine, to some extent, yes. Avnish, I would say it is next best, right, to an actual consultation with a doctor. Yeah, physical consultation, I'd say. So any other options? I'm sure if we put our brains together, we'll be able to find some solution or the other. Need skill development for, Mahesh, could you explain that a bit? Skill development for a portal. Okay. Okay. So skill development, Mahesh, could you explain that a bit? Who needs to develop the skills? Is it the doctors? Is it the social workers, or?
Dr. Mahesh, you can unmute and speak. Yeah.
Auxiliary healthcare workers and doctors both, social worker, nursing staff. Okay. So these are the options that we could come up with. For Ashok Kumar, it was just a simple solution, and he found the solution in less than a minute. And he told this gentleman, "Don't worry, your mother will be taken care of. You can just go home and relax. If the doctor, if you can't bring your mother to the doctor will reach your home. The doctor will see your mother at your place." Now, Ashok Kumar did not discuss this with anyone. So what he did was, he asked the person to go back home. He went and found a doctor who was willing to go with him to this patient's house. He took his bike, a kinetic Honda for that matter, which we are all familiar with, asked the doctor to climb behind him. They went all the way to the patient's home, saw the patient, the doctor gave the proper advice, they came back, got the medicines across to the family, the patient. And that was the first home care visit in the country. Now, did we have this earlier on? Yes, we used to have this long back. But unfortunately, today we have just forgotten about that option. Doctors and hospitals expect people to reach them. They would expect patients to come to them in their facility, in a hospital or to their homes. Now, Ashok Kumar was not stuck. He was not stuck with that prejudiced mind. For him, a solution was all what was needed, and he was willing to think openly. And he came up with a solution within no time. And that actually made a huge difference. The palliative care that we see being practiced in Kerala, and in fact, now this has become a model for the entire world. In fact, we in Pallium India see so many people who are from the Western world, from the developed countries, come and see this in action, the home-based palliative care. Yes, I do agree, we need skill development. We need skill development for auxiliary healthcare workers. Practically not feasible. First, we should send nursing care, should do video call. Mahesh, yes, there are situations I can understand that, but this was something which actually happened. So this is a real life story. And today in Kerala, we have home care teams, even in Pallium India for that matter. We have around 6 home care teams which are going out into the community, and most of the places where they reach out to, they are inaccessible by road, and often the teams, yes, in Kerala, not just in Kerala, there are places in the northeast, similar places where it is inaccessible. There are places where the doctors and the teams, travel a day or two to reach out to some of these remote places. Now, it's very simple. The logic is very simple. Most of the patients who are in dire need of palliative care, who are bedridden or physically challenged or challenged in other ways, emotionally, physically, financially, they may not be able to reach out or reach a hospital or come to a facility where they can get the care, even if they want to. So that is the logic that was applied there. If the patient cannot reach us, we reach out to the patient. So there are still limitations. I'm not saying that everything is, hunky-dory. Once we start doing this, everything will be solved. But what I was trying to highlight was what volunteering or the involvement of the community can bring to the table, how it can change the healthcare system, how it can bring new solutions which we have not even thought about. And that is real innovation, the way I see it. And it does not necessarily require, I wouldn't say it's just a public sector program. It could be a combination. I think these are things which have to evolve. We are probably taking baby steps as far as palliative care is concerned. There is potential for huge innovation in this space. And today we are even talking about, okay, so when it all started off, there was this slogan which palliative care community used to hang on to, which is high touch, low tech. So the idea was, it's not about the technology. It is not about the big machinery in the multi-specialty hospitals that you find that is required for healthcare. It is high touch and low tech. Now, here in Kerala, at least, things are changing. Now we started discussing about, at least the palliative care community has started discussing about high touch and high tech. Why not? If we can introduce technology like Mahesh was suggesting, a video call, a telemedicine, this thing, why not? We could have that also. A combination of medical and non-medical people with the involvement of students awareness program. Absolutely. So what are we talking about? The more the awareness among the public, the more people see the effects of palliative care on people and the community, the more training the doctors and the nurses and the social workers and other paramedical staff, the more the training that they get, it all adds to this new, how do I put it, a new kind of healthcare for the entire world. So we'll go back to our slide unless there is any question on any of these things right now. We don't have palliative care hospitals team as of now, our need. Kerala is more and more advanced in education, palliative care. I don't think doctor will go first instance. First they send the staff, if they need the doctor. Mahesh, doctor will go. If need, doctor will go. So again, Mahesh, what I'm saying is, I'm not talking about today's Kerala. I'm talking about Kerala 30 years back. And there was no palliative care available. There was no one trained in palliative care. But that didn't stop this one doctor and this one Ashok Kumar to take that step, that first step. So even if we are talking about a place where these are non-existent, you can make a difference. You as a doctor can actually go and meet a person if there is a person in need, if there is a patient or a family in need. So it's not about whether the entire doctors community can actually do that. It's about whether you and I can take this first step. That is what I wanted to highlight. So the debate is not about how advanced we are, how much training we have, or what are the additional skills and other things that we need. It's more to do with the attitude, the approach, I believe. So shall we move on? Okay, I'll probably share the screen once more. Just hold on. Okay. So that is where, so we've been talking about a typical volunteer, how he would approach things and how he would respond to a situation. I hope you can see my screen. Arun, please confirm.
Yes, sir.
Yes. Okay. So the definition of a volunteer, it says a person who actively takes on the task or responsibility.
Excuse me, sir.
Signed in order to do so.
Binod sir, please make it full screen.
Yeah, full screen, I'll do that. Okay. Oh, sorry. Yes, there you go. Okay, so we'll probably have one more story. This is a story of Ken Nair. Now, sorry, now he must be 65 plus. So, so it was in 2002 when his wife was diagnosed with stage 3 cancer, and she died in November 2004. Now, it was not that she started developing the symptoms in 2002. Now that happened at least a couple of years prior to that. And this gentleman was going from hospital to hospital. He's gone and consulted almost all the major, what do you call, oncologists. And then finally, when she was actually diagnosed, it was beyond the scope for cure. And she died in November 2004. Now again, I want you to imagine yourself in that position as a husband or a wife who has been with the partner, with his or her spouse, trying to find a solution for the problem from different hospitals or doctors. And then when it was diagnosed, it was almost over, right? So how would you feel as a patient or a caregiver, I would say? Just imagine that you are K. Nair. And how would you go about, I mean, what would be your reaction? What would you be going through in your mind? How would you handle that situation? Again, open to comments. Sorry, this power situation is a bit of a challenge. Okay. So my question is, imagine that you are in Mr. Nair's position, and what would you be going through? What would be going through your mind? How would you handle that situation? What would be your reaction? Angry and devastated, of course, yes. Angry at total frustration, absolutely. Dr. Sudha, could you just explain the anger? Where would it be directed to? With the health system or doctors? Angry at life, healthcare. Okay. Okay. So frustration, anger, what else? Yes. Yes. What else? Helplessness. Not able to get the cooperation of the medical systems. No clear-cut answers. So you feel helpless, frustrated, angry. And then? Anything else? Okay, I'll probably give you some clues as well. So eventually, perhaps a desire to make things different for those who suffer from similar problems. Absolutely, Geeta. I mean, I don't know about, I don't know whether I would think like that. It's good that at least you are thinking like that. Thank you very much. So actually, what happened was, probably you can again guess, you know, that when she was finally diagnosed, you know, with that advanced, in that advanced situation with cancer, what would the doctor have told this gentleman as the primary caregiver? Can you imagine what the doctor would have told him? not giving any hope. Yeah. I'm sure most of you would have gone through this situation at some point in time or the other. I'm sorry, we can't do anything at this advanced stage. Absolutely. Sorry, we can't offer much help, much medical help. So yes, mostly it is that sorry, we cannot do at this advanced stage. We can't offer much. So let us take that one sentence. I'm sorry, we can't do anything at this advanced stage. Suppose you are hearing that from a doctor. How would that make you feel? Or in other words, typically what you get to hear is, why didn't you bring her here earlier? Couldn't you have, brought her here earlier, or, So how does that make you feel? Now, these are not situation, regret. Anything else? Regret that, okay, I couldn't bring her here earlier. So there is a feeling of guilt that is thrust upon him. By the community, we have to be accountable for women's health, for screening. Actually, yes, in fact, not just breast cancer. In fact, when he took her wife to the hospital, prior to that, what I understand is she was supposed to go through this, what we call a pap smear test, which was a basic thing. It should have been advised by the doctor, but that didn't happen. And that was the reason why it went to this stage. Yes, so that feeling of guilt, it is not just something which, it has got nothing to do with what he did actually. He did all the things that he could do. He took her to all the best hospitals, the best oncologists, and to a large extent, it was the healthcare system which let him down. But after all that, finally the doctor says, you could have, why didn't you bring her here earlier? So this actually happened. This is something which the doctor told him. And of course, that is when, just like Dr. Geeta said, there are many paths that we can take at that point. Of course, we are feeling that anger. There is the frustration, helplessness, guilt, and whatnot. It's a terrible situation, as you can very well understand. But then there are choices, how you want to react. Now, in a typical situation like this, you find that sometimes you take out that anger with the doctor or the healthcare system. You might even, this is not something which is new in our country, at least in India. You hear stories of patients or their families going to the hospital, beating the doctor, or beating up the doctor or the nurse, sometimes even going destructive, take down the entire hospital. So that is one way of reacting. There is the other approach that some may take, that you take the legal course. You sue the doctor, the hospital, the doctors or the hospitals, who he had taken her to prior to that. So you could always try to win that battle. But then his choice, Mr. Nair felt otherwise. He didn't want to go after the system. What he did was, he directed all his energies into making sure that another person in a similar situation goes through a similar fate, or what he has gone through, the fate, his wife's fate and his fate. That is not something which he wanted someone else to go through. So he started dedicating his time for palliative care, and you can see a palliative care volunteer is born. Now, why I narrated this story was, yes, Dr. Sudha, it's all of us, we need helping hands. I mean, it's not just him. Now, today he is offering his hand to people like you and me. He offers his hand supporting the healthcare workers who are with us, the doctors and the nurses. He leads a team which goes out, at least he was doing it at least up to some time ago. He used to be the leader for a home care team. And he used to be in touch with the patients. He used to organize the route map for the day. He used to be, he used to keep a diary of the different, the patients and their current status. And he was always a call away for any of these patients. Now, there are hundreds and thousands of Nayars, care Nayars around us. The only problem is we find it very hard to identify these people. Now, if you go out to the community and keep searching for care Nayars, it will never happen. The only way out, as we see it, is for them to come to you or to us. The volunteers, if we go after the volunteers, trying to identify a volunteer from a community, it's going to be very, very difficult. So the volunteers should actually come to us. And how does that happen? It's very simple. What we find works is we start offering the care the way we want it to happen. And seeing this, people will come forward. People like K. Nair will come forward to support, to help us out in reaching more people, in reaching the community, offering their time and resources. It's not just the time. So I just gave this as an example of volunteering. Of course, they can take up any kind of role in palliative care. That's what our experience tells us. Often we tend to limit their contributions, in the sense, you may want them to do some simple chores like, taking a patient to the hospital, or sometimes, getting them medications, or maybe offering some financial help, like someone mentioned earlier. But let us not limit ourselves. They can actually solve a lot of the problems that we find in palliative care today, and not just palliative care. I'm talking about healthcare in general. So it's about understanding their capabilities, and of course, let us not ignore the fact that they need to be trained, because sometimes without the proper training, they may end up doing more harm to the patient and the family, even though they have the heart to do good. Like, for example, a simple thing like what now we are all familiar with, the hand wash, routine. Thanks to COVID, we have all been taught to how to wash our hands, right? So that simple hand hygiene before and after seeing a patient, when you are with a patient. So if a volunteer is not properly trained in doing that, it might end up, he might end up taking a deadly disease from one patient to another. And a palliative care patient obviously is very vulnerable, already vulnerable, prone to diseases, and that could mean death also, sometimes at least. So those things need to be taken care of. There should be proper training. Communication skills, that is another area which we need to focus on. Proper communication skills should be there for the volunteer. Again, you can do more harm than good if you're not properly trained. So it's not a joke, it's sometimes you feel that, okay, having volunteers will solve all your problems, but that again comes with its own set of challenges. You need to be able to manage them properly. And sometimes it can it can be counterproductive also if you don't get the right person and with the right kind level of commitment and all that. So all these, but essentially we need to understand what makes them do it and what they're looking for. Fundamentally the problem is they don't do it for the money. So we can't excite them by offering them money. It's something else that they're looking for. So what is it that we're looking for? Just like we discussed about Mr. Nair, he had something else in mind. If you are not able to provide him what he wants, he will not feel satisfied and he'll stop contributing. Of course, everything depends a lot on the local culture and individual. Like earlier, one of our friends, sorry, I keep missing that name. Yeah, Mahesh mentioned, so sometimes it might work in Kerala. What works in Kerala may not work in Tamil Nadu or another part of the country. So that's a practical reality, yes. So how much time do we have? Yeah, another 5 more minutes and we'll try to close. Again, any questions so far? If there are any questions, I can take those questions, or probably I'll finish in another 5 minutes and then we'll have a question answer session. What do you think, Dr. Sunil? Is that good?
Yeah, we can go for another 5 minutes and then
Okay.
talk for.
So the collaboration is something which you are familiar with, I guess. So the need is very high now because the challenges are many, and by ourselves there are limitations on what we can achieve. So that is where, if we have more ideas, more expertise coming together, probably we'll have innovative solutions and naturally our productivity will be high. And the scenario is also changing, which makes it even more relevant, important. Like earlier, there used to be probably one palliative care center in maybe 100 kilometers area. So now we have multiple people, multiple organizations. The health, it is also part of the healthcare system, at least in some of the states in India. And even at the national level, there are changes that are happening. At least we have a national program for palliative care. There is some funding available at the national from the National Healthcare Fund, or rather NHM, through the NHM. So those things mean that there are other people who are offering solutions, and if we can work together, a lot of problems could be solved. And there are other NGOs also which could work together with even the private sector or the government, which can solve a lot of problems. Like, for example, earlier we mentioned about financial support or say, for example, even sometimes children who are most affected by, once you have a patient in the family, especially if he or she is a primary breadwinner for the family, and that person is bedridden or not able to make an income, one thing that we see across the board is that the children's education is affected. Now, what does that mean? It means the next generation is also going to suffer. So if we have a solution to take care of the children's education in such a scenario, where another NGO working in that space could step in and solve that problem, we would be able to take care of that families, at least the next generation will be safe. Providing food kits and those kind of basic things where other NGOs, other government facilities also could step in. So if we have a collaborative working system, we can reach out to more people, we can have better outcomes also. Now, for example, we work with a lot of what we call link centers, and some of these link centers could be community-based organizations, it could be NGOs independently working, it could be a hospital, like for example, we even work with the Medical College Hospital in Trivandrum. Now, each of these relationships, it's very difficult to establish and even more difficult to maintain, because naturally we are all human beings and we have our own set of egos and the challenges that we face as human beings. So it's difficult to have these kind of relationships established and maintained. But then, as long as we are clear that this is needed for the people who are suffering, if we can come together, a lot of problems could be solved. And I'll close with this one example, because this probably explains a lot of other things also, like the advocacy and fundraising that I wanted to share. So Sita actually had a surgery. She had a growth in a spinal cord. So after the surgery, she was not in a position to walk or travel. Then there was need for physical rehabilitation. Some physiotherapy was required, and then slowly things started improving. And then came the next challenge, and that was that she was not able to do anything meaningful with her life. So and of course the family also was not financially well off, so that was another challenge. So what happened was, some of our volunteers came forward and then taught her how to make these what you call jewelry, the kind of jewelry you must have seen, these jewelry making kits from where you can make this jewelry. But then she was trained to do that. She had some artistic talent and she started making these by herself. Then came the next big challenge. Now it's all right to get this done. The jewelry was there, but then how do you convert it into money? Of course, it needs to be sold. So how do you expect this person on a wheelchair to go out and sell her products? So another group of people came forward with a suggestion, and that was a good suggestion, that we could probably get her to sell this jewelry online. So the idea was good, but the problem was she had no training in computers, or she didn't have a computer or internet connection or anything of that sort. Now, the same team said, okay, we'll teach her how to use a computer. So she was taught how to use a computer. She took it up as a challenge. She did get herself trained. And then the next problem is she doesn't have a computer or an internet connection. Now, someone with a good heart came forward. Of course, we started spreading this message, and someone came forward and said, okay, I will donate a computer, a laptop. And then the local, the cable provider said, we'll provide a internet connection for her. Now, that is when she was able to start selling jewelry, and now she is the only earning member of her family, and her parents are with her, and she takes care of them. She's still on a wheelchair. There are other challenges also along the way, like they didn't have a proper road access. That was when the local people, the neighbors came forward and said, okay, we'll provide some more space from our area. And then they put up at least a kacha road, as we call it in India. It's not a proper road, but at least a vehicle can travel up to her house. It's wide enough. And then the local municipality, the panchayat, came forward, and it laid a better surface for that particular path, and it was motorable. Now, if you look at this example, what has happened is Sita was a, yes, thank you Sunil for the reminder. Sita was a productive member of the society. She had her skills which could be used by the society, but she was not in a position to utilize her skills, be productive, because the environment was not conducive. When the people started stepping in and providing that support, like the team which took care of her what you call the physiotherapy needs, the person who offered her a computer, the volunteers who trained her in jewelry making and the computer training, and the panchayat which stepped forward in making sure that there is a proper road access, the neighbors who contributed. Now all this changed not just Sita's life. This changed everything for the family, the community, and we have a contributing member to the society. Now this is a brilliant example of collaborative working. If we are working in silos, each one by themselves, it would have been very difficult to achieve this kind of a transformation for Sita, the family, and the society. So we'll stop here. I think we'll take some questions. So there is this. What I wanted to say was, once the awareness was there with the community, all these things started happening, including sometimes we say that, okay, it is the funds that are needed. Without the funds, we will not be able to do anything. Now, here is an example. You don't actually need the funds. If the community is involved, the laptop would come, the internet connection would be there, the road will automatically happen. So a lot of these things don't actually require money. A lot of these things, I'm not saying everything. And even if it comes to raising the money, again, there is a possibility of the community themselves doing it. So advocacy, again, it's about what you call creating more awareness, and that awareness leads to more participation by the community, and of course raising the funds, and all those things follow. So because of lack of time, I think we stop here. I'll take questions. I think it's already 4:30. Sorry about that.
I don't really know how to raise my hand. So can I ask a question?
Yes, sure. Go ahead.
This is about the situation in Nepal. There's been some pioneering work done on palliative care by Dr. Dan Monday and some other palliative care doctors. Dr. Dan Monday is in the UK and works with the hospital that Dr. Dhum Kumari is located in. Some national happens is it's still confined to hospitals, a few hospitals, 2 medical colleges in Kathmandu, 1 hospital in Pokhara. So there isn't much going on, and so the question is, but we have a very strong community volunteer program. This is in fact an excellent program on the base, could have been a model for the ASHA program. Here, these are volunteers, they're not paid. So they do it because they really want to volunteer. So how, we want some help or understanding. This is my sort of personal take on how to set up a community-based program. Is there a possibility to visit, for people from Nepal to visit and observe how you're using ASHAs in the program? Is there a possibility of any technical support from Pallium India if we are, sort of interested to go ahead? So these are some issues. And I would like to ask Dr. Dhum Kumari also to sort of come in on this, because she's located in a different city and they are doing a lot of excellent palliative care work. Thank you.
Yeah, thank you. Yes, of course. And that is one thing which we would love to do. Essentially, we would like to work as a catalyze palliative care in not just India. We also offer our expertise and support to our neighboring countries as well. So So to get things going, there are training programs which we could organize for you. I'm sure we'll be able to help you out with that. Then including volunteer training programs for that matter. And like you mentioned, if you need to make a visit, see how things are happening in this part of the country, most welcome to do that. We would be able to facilitate that. And sometimes we may be able to even connect you with the right kind of people who would be willing to work with you. Even there are funds, or rather foundations, which are willing to support people like you set up a palliative care facility. So there are a lot of possibilities which are available, which we could explore. Please do be in touch, and let's at least start off with yeah, yes, severe community visit, but it's just limited to 20 kilometers within a hospital. Yes, Dumkumari and Dr. Geeta Rana. So we'll be happy to support you. Arun, if you could just note it down and get back to Dr. Geeta Rana on how we can go about doing it.
Okay, sir. Sure.
So Dr. Mahesh asked us how to start a palliative care unit.
Okay, Mahesh.
How to start?
Okay, so some of the things I think that it's already mentioned in the slides, like see, you're from within the country, right? From India, I guess.
Yes, Rajasthan only, sir.
Right.
North Rajasthan.
Okay. So here we need to have what you call an RMI certification as a recognized medical institution, which means that one of you from within your group should be, yeah, we also set up in hospital, yes, should be trained in palliative care. At least a 10 days training program is compulsory, especially around the use of opioids. And that would ensure that you have you have access to morphine and other such opioids, which we believe is a big step forward, one. And of course, like we discussed, getting the community involved is a big step forward, which means a lot of other things which you need to get things organized. It might be helpful for that. Plus some of the registrations, if you're trying to start on your own, you might require certain registrations or licenses. It all depends. It all varies from place to place, state to state. So make sure that you go through that the norms that are laid out by the government. Again, we could probably get you connected with a few people who would be interested in setting up something in Rajasthan. I'm sure there are at least a couple of people, a couple of foundations also who are interested in working with people like you. So I think that it's again about understanding the local community, the needs. I would say the first thing to do is identifying the need there, the kind of people, the kind of palliative care needs that are there in the community around your place, and then start reaching out to them with the knowledge that you've acquired. If you start off with one patient, that is a big first step, and I'm sure you will find solutions to your other challenges as we go on. So in addition to what we just discussed, if you want specific information on anything to set up a palliative care clinic, again, that is something which we can look into, especially information about the current, the set of trained personnel available in Rajasthan, or the other clinics that are available. We can connect you to the right people, of course. And I'm delighted to note that Mahesh, you are thinking in those lines. Yeah, yeah.
Anybody else want to ask? Yeah, Dr. Sudha is asking about palliative care training. Palliative care is a teamwork. How do we train team?
Um, how do we train the team? So again, if you go back to one of the slides that we just skipped through, in fact, the team includes all the people um, in the healthcare system and the volunteers. So from that perspective, each one requires a separate kind of training. Like for example, what is required for a doctor is different from what is required for a nurse, and that is different from what is required for a volunteer. So that is the reason why we have a range of training programs for different people from different background, right? So I'm sure again Arun will be able to share some more information on this, the kind of programs that we run, even the content and all those things, which could also be shared with you if you feel like. So I think since you are already trained, Dr. Sudha, that again is a good beginning, I would say. Maybe at least one more nurse to support you in your work. That would make a good combination to start off. What should be the remuneration of a doctor? Difficult question, Archana. That is, it again depends on the local availability of the doctor, the kind of remuneration that a typical hospital would be paying that person. Now, I would look at it from a different angle. As a volunteer, what I would like to at least try out is whether I can get a doctor for free. Um, so there are so many doctors good at heart. They want to do something good. They want to support people, and they don't have an opportunity. In fact, I stay in a place called Cochin, which is around 200 kilometers from Trivandrum, where Palin India, the base is. Here, I keep getting people who ask for help. And what I do is I reach out to doctors whom I know. And there are at least a few doctors who are willing to support me. They are willing to come with me, even make a home visit. And there are people who are willing to do it for free without any remuneration. So my first choice would be to find a doctor who is interested in offering his or her services without a remuneration. That's also a possibility. This service should be free. Now, is it a statement or is it a question? Like, should this service be free? Sorry. Okay. Okay, so that's, you believe that I don't, we can't see your name, but so it shows as Galaxy M31 anyway. This in most parts of the country, I think right now these services are being offered free, mostly because it is offered by NGOs and the government, the public healthcare system in most cases. But that, yeah, Dr. Radha, thank you. But that need not necessarily be the case. So there is a situation today in Kerala that probably for the first time in the history of healthcare, the balance is now tilted in favor of the have-nots. In the sense, people who don't have money, they get good quality palliative care in their homes and they die peacefully. Whereas the rich end up in hospitals. They have the money, but unfortunately, most of the multi-specialty hospitals where they end up, they don't offer palliative care. Now, which is also not a fair thing. It's injustice, I would say. So we should be able to have a system where we can access palliative care free, but that doesn't mean that everything should be free. If I can get palliative care by paying money for the services, I'd be happy to do that. And I believe there's a large segment of the community who are willing to do that. So do you have a list of places where you can go do service and get more familiar and practical approach hands-on and palliative care? Absolutely. I'm sure Dr. Sunil will be able to help you with this. We already have a list of experienced people, people who are already running palliative care centers, people who are practicing palliative care. So we can connect you with that. Dr. Sunil, I believe you're the right person to.
Yeah, you can write to us where which state would you like to go so that we can help you.
I think the list of palliative care services, I mean, palliative care centers is already available in our website also. Yeah.
So I think we have to wind up now. So thank you. I think all of you enjoyed this session, even though this was not a medical session. So thank you, Binod, for enlightening us regarding different hurdles that we have to cross for starting palliative care, and also good to see that there was a lot of interaction. So thank you very much, and thank you all for the interactive session. And from this discussion, I see that many of you are interested to know more about how to start palliative care. And if you have,
Dr. Sunil, you are muted.
and we can then forward it to Binod if needed to get this info. So we encourage you to write to us regarding that. So thank you all.
Thank you very much. Thank you, Dr. Sunil, Arun, for organizing this, and thank you all for being so patient listeners and making you part of your community. Thank you for letting me in, I must say. And again, I must say that I enjoyed this session. Thank you for your interaction. I have also given the link, answer to where all this palliative care facilities available in India. I think it may not be exhaustive, but I think you get a fair idea about the people, I mean, the centers. Thank you very much once again.
Okay, thank you, Binod sir. Thank you, Sunil sir. And thank you all. We are winding up the session. I request everyone once again, I request everyone to please do the feedback now. And one more request, kindly submit your assignment as soon as possible. That's a request. Okay, thank you, sir.